were talking about lixisenatide, and then you mentioned that there was a combination product the FDA was looking at too. So that's what? That's lixisenatide plus insulin glargine.
Right.
So how does that all fit, and where are we with that?
I'm going to defer to Julio
Julio.
because he did all of the
Before we
studies
get
with
there,
it. Yeah.
lixisenatide has been tested with other agents as well in the Get Gold program. It's a broader program.
Yeah,
not
I
just-
did ask
but
about that
one
question. Tell
thing
me
it-
about
But it's
that.
not widely used. It's
no,
not, it's
no.
not,
I think it was tested because of regulatory in combination with metformin or sulfonylureas. But if I were to use lixisenatide, I will use it in combination with basal
I
insulin.
totally agree.
I mean, I would not.
But the program
for
was
the
broader.
oral agents, you have other options there that work very well.
So there's a combination drug.
Yeah,
yes.
there's a combination for this program. Is called the LixiLan program. So there is the LixiLan-O and the LixiLan-L. We've been involved in both trials, and is the combination of insulin glargine plus lixisenatide in two different ratios, 2:1 or 3:1. So that for 1 unit of insulin, you have 2 micrograms or so on, or 3 micrograms. But it's 2:1 or 3:1. The point is that you give it in combination, and the LixiLan-O is in people who failed to oral agents. And so it was comparing LixiLan that has combination insulin glargine versus plus lixisenatide versus insulin glargine alone versus lixisenatide alone. Really head-to-head active comparators. And the results were very robust in terms of what you can get there. You have a reduction from an A1C of 8.1 to 6.5% with the combination of the two.
I mean, let me just stop you.
6.5.
That is an impressive
That is
number.
pretty darn good. Pretty darn good because it's associated without weight gain and without increasing hypoglycemia. Now, if you want to use insulin alone, that's fine, because it did get it to 6.8, but with weight gain. If you want to use the lixisenatide alone, that's fine, but it gets down to 7.3. But you get down to 6.5. Now, the FDA did not approve Lixi in combination with oral agents. It did approve it in people who did not get good control with basal insulin alone. Because they felt, no, I mean, you have the other options. We don't want to do it right now. So they said, yes, you can use it. And for people who want to know about that, you can only use it in people who have basal insulin and need to advance therapy. And so you switch to that. When you do that, they compare the basal insulin with insulin glargine versus insulin glargine, Lixi, and then you get people who were from 8.5 down to 8.1, and then you get down to 6.9 when you do the switch. And if you continue intensifying the insulin glargine, you get to 7.5.
So Julio, can I ask you a question?
Yeah.
In those studies that you're talking about, where they were comparing lixisenatide to glargine, the combination LixiLan or Lixi to either the components, they had a run-in period.
Correct.
A run-in period of 4 or 6 weeks.
Correct.
Where they took people and titrated them as much as they
Correct.
could. Do you think that they would have even gotten more reduction? Because I noticed that in some of the other trials done with degludec, they didn't have a run-in period.
Correct. And there's a difference because, I think that both formulations are great.
Very
because
good.
Very
Both.
good. I mean, the same impressive results you get with IDEC Lira, which you gain in people in similar design, people who fail oral agents, who are remain on metformin, then you put it on IDEC Lira versus IDEC, which is degludec alone, or Lira alone. You still get down to 6.5%, just that the degludec in this case went down to 7%, so the delta looks a little bit greater, but again, both get around 6.5%, except that there's a difference. They did that right from the beginning.
Right.
Whereas in the Lixi, they have a period of 6 weeks of optimization of the insulin, so they brought it down from 8.5 to 8.1, and then continuing with the glargine down to 7.5.
There are some
versus
new
6.9.
studies that are ongoing which are using the combination
Right.
right up
Right up
with-
front.
But I
together.
mean, those are little
Small
intrinsicies there.
I
mean,
think it's important though, because you need those studies, because
sure.
the label right now for both combinations is to use the combination when one has failed. One of
Yeah.
the two.
Either
And that's a
GLP-1 or insulin.
limitation.
That's a
Yeah.
limitation.
Sure, it's a
regulatory
limitation. It's
So-
a limitation, but I think it's all right because it's the low-hanging fruit. A lot of practicing physicians out there, who we said before, they've done very well. I mean, unbelievable. I mean, good credit to the people with the practicing physicians out there who use basal insulin, but they are frustrated. They're frustrated because they cannot get to the goals that they want. And when they need to advance, they don't want to use prandial insulins. Here, switching to a co-formulation allows the chances to advance therapy, and that's why the FDA approved the indication.
Now, you pointed out that, I'm sorry, go ahead.
I was just going to say, it's really easy also for the patients. I mean, you're basically taking them from something they've been doing every day. It happens to be a little different formulation. You talk a little bit about where to start, and they continue to titrate it.
still
They've already
same
done
pen.
it. The actual education part is minimal.
Same, it's the same.